Welcome everybody. It's turned 2 o'clock, so we'll get started. So welcome everybody to the Staffordshire Health and Wellbeing Board today, which is a meeting held in public. First, before I go on to apologies, I just want to note for the Health and Wellbeing Board that Johnny McMahon isn't here today because he stepped down from his role in the Cabinet and consequently as co-chair of the Health and Wellbeing Board. So I'd just like to formally thank him personally as a colleague, but also for all the work he's done in his Health and Wellbeing Board role. Okay, so if we move on to apologies, we've had apologies today from Michelle Hickmont, and Karma Warren is attending on her behalf. Peter Axon, Rachel Gallio, Simon Fogel and Craig Porter. And Claire is on the screen. So she's unable to join us in person today, but she's presenting, so thankfully she's been able to join by Teams. Okay, so if I could ask if there are any declarations of interest, in addition to ones already declared pertaining to any of the agenda items. No? Okay, thank you. And if we could turn to the minutes of the previous meeting. I wasn't present, so I will turn to members of the board to if they would go through those minutes, and if you could just raise any inaccuracies or any matters arising from the minutes. Okay, no, so we'll sign that they're a true reflection, a record of that meeting. And the next item is any questions from the public, and I believe we haven't received any questions from the public. So we'll now move on to the first tabled agenda item, which is an update and signing off of the Health and Wellbeing Board strategy. And Claire McIver is joining us to present this item, and there is a copy of the draft and updated health and wellbeing strategy in your packs. So Liam, what do we? How do we get Claire in?
I'm here.
Oh, you're there, Claire. I'll turn my microphone off then. Thank you. Over to you, Claire.
Thank you. Thanks, Alison. For anyone that doesn't know me, I think I probably know most of you, but I'm Claire McIver. I'm Interim Assistant Director for Public Health and Prevention at the County Council. So what I'd like to just quickly do today, hopefully won't take up too much time. You'll all be aware that we've been working on a refreshed version of the strategy for the Health and Wellbeing Board. Over the past few months, we've discussed various iterations, and subsequently following wider consultation with the public and stakeholders, the developments and amendments that we've made to the strategy as a result of that. So what I'm here to do today, I guess, is seek the board's approval for the final version of the strategy, which is the one that's in your pack. There aren't any significant changes, just the ones that we discussed at the last meeting, so it shouldn't be anything that's a surprise to any of you, hopefully. Within the report as well, there are some points for the board to note in terms of specific issues, areas of focus, potentially additional work that might be required for each of the 4 priority areas. So that follows a piece of work that was done by John Topham with colleagues to scope and map existing work and existing sort of priorities and challenges against each of the 4 priority areas to understand where those gaps might be and where we might want to suggest the board focuses its efforts in terms of driving forward improvements against the key outcomes. There's a recommendation that the board identifies a sponsor and a lead for each priority. We think that's really important so that there is some accountability, but particularly just to maintain that momentum and make sure that the board is able to sort of track progress and performance against each of the outcomes and have that sort of continual feedback loop, I guess, coming back into the board. And you'll also see within the pack there is a recommendation for specific outcomes and a reporting cycle against each of the priorities. So the updated strategy was brought to the board meeting in March, and then, as I say, further iterations were discussed at subsequent meetings. The final version incorporates all of those amendments and is recommended for approval today. You're aware of the 4 priority areas that we've identified. So that's health in early life, good mental health, healthy weight and healthy ageing. As I say, there was a scoping exercise conducted, and that was carried out to identify existing work programmes as well as issues that the board might want to consider. So you can see those from section 7 onwards in the report in the pack. So generally those areas of additional work tend to focus on sort of streamlining governance, and I think that links quite nicely to the item that Natasha will be covering. Ensuring that those 4 areas are given sort of sufficient priority by specific organisations and partnerships, a focus on prevention and early intervention, and having that whole systems approach to a number of these really complex issues where we know that one sort of method, one approach won't necessarily deliver any significant change. What I think we need to think about is how we come together as a board and, as I say, allow ourselves some a sort of particular way to sort of bring together the performance and monitor progress against all of these areas and check we are actually understanding what those gaps are and whether we're delivering against them, whether the board is doing what it needs to do in terms of seeking assurance on those gaps being filled. And I think probably one of the best ways we can do that is by identifying a sponsor and a lead for each of those priority areas. And that's really so that we can have some leadership for each of the actions required and make sure we're driving forward that progress. We also talked about how we might monitor the impact and progress against some of those areas, and there's been lots of conversations happening in the background about how we do that in a pragmatic way but also a robust way. I think we all know that the 2 overall outcomes the strategy is trying to achieve in terms of reducing infant mortality and increasing healthy life expectancy are both very complex, multifaceted issues, and we know that a range of factors influence those, and it can take many years to achieve improvements. So that said, we've suggested a number of suitable indicators that can be used as sort of proxies, I guess, and measures to demonstrate progress against achieving those outcomes in the longer term. And you can see those in section 19 in the table in your pack. So, for example, for health in early life, the proposed outcomes are reducing smoking in pregnancy and increasing breastfeeding, both of which we know have a direct impact on rates of infant mortality. Good mental health, we've suggested a reduction in the suicide rate, a reduction in admissions for self-harm, reducing emergency admissions with a mental health diagnosis, and management of depression in primary care. So you can see the range of measures there that have been worked through by analysts and epidemiologists and partners to try and think about the most practical and pragmatic data sources we have access to that we're confident are robust and provide us a sort of reasonable indication of each of the different outcome measures. What we'll then need to do, and is happening in the background again, is identifying suitable performance indicators for each of those outcomes so that we can allow that measurement step by step throughout the year for each priority. So in terms of reporting structure and frequency, the recommendation is that the sponsor and the lead provide a full report against each priority annually, and that will obviously be a collation of various data sources from partners, different groups that exist, governance structures, as well as that necessary sort of professional and public input, which I think is crucial in terms of setting that data against the national context and applying that interpretation of all the information. So those are the recommendations within the report. You can see the final pack, the final strategy, hopefully within your pack, and I'll leave it there and happy to take any questions.
Thank you, Claire. So any questions for Claire on the strategy and those outcome measures and how the strategy is going to be monitored and reported? Julia?
First of all, Claire, I apologise for not having raised this before, but I was reading through this again last night, and there's just one element. I know what we're trying to achieve, and overall, I think this is a good strategy with clear outcomes, and totally agree with you that there needs to be a named sponsor for each of the areas of work, because there has to be that accountability to make sure that things happen. But it's on page 10 and it's under healthy ageing. And I know I've referred to this over the years in my NHS days of the need to reduce deaths in hospital. Well, I think we all know what that means. That means we need to increase the deaths elsewhere. And that's going to be people's homes, whether it's in a nursing home, a care home, or their private home. I just fear that as a society, we've lost the experiences, the skills to know how to deal with a dying friend or relative in their home. In care homes and nursing homes, there is a tendency, because they have to manage risk, they have to manage the potential of families suing them, of the easy option is to refer people into hospital. I know in my days of urgent care, that was often the way that they managed that risk, and I quite understood why. So I think it's almost a societal thing, and I don't know whether it's actually one of those performance indicators that you're on a hiding to nothing. As a society, we would need to be accepting of risk ourselves to a far higher degree, and to relearn the skills that probably our grandparents had, where most people died at home. We all say we'd like to die in our own bed, but actually society, I think, would need to have a huge change of attitude before that can happen. Otherwise, I think healthcare professionals, social care professionals are going to end up in between a brick and a hard place, to be perfectly honest. You know, unless things change significantly, a clinician, a social worker, if they feel that somebody is at the end of life, unless it's a managed decline because they're a cancer patient or somebody with long-term conditions, I think their only option at the moment is to refer into hospital, which is what happens. So I don't know whether that particular indicator, whether it's wise to put in. I totally understand why it's there, but when you think through how we're going to do that without a significant open discussion with members of the public, because if I was a doctor, a nurse practitioner or a paramedic going into somebody's home and saying, well, this person is dying, they are better left here, rather than taking into hospital. I don't know what our ambulance colleagues would say, but that's a very, very difficult decision for somebody to take. So that's the only query I have, and I do apologise, Claire. I should have raised it with you before, but it was just something that crossed my mind, that potentially that's a very difficult one.
Richard, do you want to respond to Julia?
Yes, so if you ask people where they want to die, about 90% of people say that they want to die at home, and about 50% of people actually die at home, with the other 50% dying in a hospital. Our figure in Staffordshire is about 52% of people dying in hospital. The best performing kind of health and care systems manage about 40%. So we're at least 12% adrift from the best. So I think there's an opportunity there. I do agree that it does require both a conversation with citizens and also conversations with our clinical colleagues about how we manage people at the end of the life. But I would suggest it's an aspiration, but a realistic one, to try and reduce the number of people going into hospital right at the end of their lives. I think we're a long, long way from getting right down to that 10%, but I think a reduction of 5 to 10% over the next 5 years or so is realistic.
Okay. Thank you, Richard. Claire, did you? Oh, sorry. Tim?
Thank you. my question really is on the same indicators around healthy ageing. I thought a lot of the aspirations within this section were actually very positive around promoting strengths-based culture and encouraging people to be independent in later life and so forth. And yet the measures to look at that were around reducing falls, reducing emergency admissions, reducing deaths. Now, all of that in a sense is right, and I can see the links between the two, but I just wondered if there was at a stage in this some way of measuring the more positive independent life elements as well as part of our work, because it goes from a very positive view of ageing into a very kind of medical model measurement of the outcome of that, and there seemed to be a slight disparity between them. Thank you.
Claire, in terms of those outcome measures, do you want to respond to Tim on that?
Yeah, I can do, and I think that the same applies to both, really. So as I briefly mentioned, the process that we've gone through with the analysts and the epidemiologist and some members of our team is to look at the data sources we've got available effectively, to sort of review those in terms of how robust they are. So, do we have a high proportion of data that's for that category, just there's nothing filled in, for example, and which makes it a little bit less useful, or is it perhaps a synthetic estimate, so it's actually a bit of a guess based on sort of national averages and the demographics of our population and things like that. So we've tried to pick out those indicators where we feel it's a really good representation of actual delivery or actual progress or a real sort of representation of what happens locally. So we are limited somewhat to what we can include. That said, I think you're probably right, Tim. I think it does sort of nudge towards the deficit model, doesn't it, rather than the strengths-based model we're talking about in the body of the report. So I think what we could perhaps do is think about where we can weave in some of the measures that we're starting to build up through the Supportive Communities programme, for example, and I'm sure there are others that partners have access to as well. So we're pulling together a whole evaluation framework which looks at how we measure things like the strengths-based work, people's access to information, advice and guidance, and sort of independent living tools that help keep people out of social care and living well and living independently at home using that strengths-based approach. So I think there probably are things we could start to weave in. I don't think they're perhaps mature enough yet to put into the strategy. But I think what I'm suggesting anyway as part of this is that it's a live document and it's continually reviewed and refreshed. So what we could perhaps do as a board is look again in a few months' time and say, okay, well, do we feel now there are some additional indicators or performance measures that we want to include, and get the board to review on a regular basis that reflects a bit more of that strengths-based working. Does that feel perhaps like a way forward?
Thank you. Yes, and Tim's nodding there. Yeah, can I just, before I bring you in, Helen, can I just sort of build on Julia and then Richard's comments around the reducing deaths in hospital, because I actually think that's that's certainly been something that's been a real aspiration and should continue to be a real aspiration. And if we actually think about this strategy and the Stoke-on-Trent health and wellbeing strategy needs to then feed up and inform the strategies for the ICS and ICB going forward. I think it's really important that that's in there, because actually the only way we're going to do it is by true integrated working with health and care and our citizens as well. So I think it's it is an aspiration, and as Richard says, we are slightly adrift from the average and from that 10% aspiration of patients dying in hospital. But I think it's really important to continue to see that as a real goal that we need to work to. So thank you. Sorry I just thought I'd do that before we move too far away from it. So Helen.
Thank you. I wanted to talk about the health in early life indicators, if that's okay. And I understand absolutely the link between those two and the priority about reducing infant mortality. But I also think when you think about the wider determinants of health and why health in early life is important for the rest of someone's life, to put them in the best position to have the best life they possibly can. So a decent education and so on. I wondered if it was, personally, I would like to see an additional one included there, which kind of moves us on from infant mortality. But I think and we do measure it every year, the good stage of development indicator as children start school, which is kind of a rounded suite of indicators around their well-being, their progression, and indicates the direction of travel in terms of their life. And I just thought that might be a useful one to try and get almost the broader outcome in terms of that best start in life, then playing into the rest of their life.
Again, Claire, can I ask you to comment on Helen's
Yeah, I mean, I think
suggestion?
You're best placed to sort of know what's going to be the most useful, I think, in terms of that priority, Helen. So I'm happy for us to, it makes sense to me absolutely to include it. So if we just do the same piece of work to look at the access we've got to that data and how routinely it comes through and whether we feel it's robust, it sounds like it probably is from what you've just said, then I don't see any reason why we couldn't include that as long as everyone else is happy with that.
Okay, thank you. So any other questions for Claire, or can we move on to the recommendations that the board are asked to approve and note? Okay, so we're asked to approve the joint health and wellbeing strategy for 2022 to 2027. So I would suggest that we approve that, but record those two areas that we're going to look at in a little bit more detail, and to bring back to the next meeting, Claire, with those updates. Okay, thank you. So are we happy to approve? Yep. Okay, thank you. We're asked to note the issues for the board to consider and additional work required for each of the 4 priorities. And we're asked to identify a board sponsor and a lead for each priority. Now, again, I was looking at Claire and Richard. How do you want us to bring those names forward? Do you want are you going to recommend some names for the board to accept today, or?
So I think it probably needs a little bit of work in the background, doesn't it? Because when we've asked previously in the actual meeting, everyone looks at the floor and we have tumbleweeds. So unless anyone's got a clear sort of nomination today or a burning desire to do that themselves, which is great if they have, perhaps if John and I and with Richard go away and have a little think about who could be a suitable representative for each priority. Possibly we have a couple so that we've got different organisational representation. That might be the best way forward. So we've got a good spread across perhaps local government and the NHS, for example. Then we could come back with some recommendations if everyone's happy with that. But I think people need to be prepared that they might be approached and sort of put forward as a suggestion. Obviously, we won't do that without asking anybody, but we're going to need to sort of pick some names out ultimately and approach people.
Richard.
Thanks, Chair. Yeah, I mean, I think if there are any volunteers, either immediately or in the next week or so, that would be fantastic. If there's more than one volunteer per priority, we could have a little mini election or something like that. I think in the absence of volunteers, perhaps if we give Claire and colleagues a mandate to gently approach us and then harry us if necessary in order to fill those 8 positions, I'm sure that would help make their job easier.
That sounds a very pragmatic approach, Richard. So I would suggest that that we accept that as a board and bring that back with an update on that to the next meeting. And finally, the final recommendations is to approve the outcomes for those priorities and the reporting cycle for each priority. So again, there'll be some just work on those two outcome for those 2 priorities. So Claire, can we record that you'll come back with those updates to the next Health and Wellbeing Board?
Yep, absolutely.
Okay, thank you everybody.
Thank you.
Thank you. So, if we now move on to the next agenda item, and this is a presentation on the Fireside project, and Carmel is going to present this to us. Oh, sorry, Tamsin, right, with Carmel sitting beside her. Yes, okay. And so this is a project that's in collaboration with Keele University, looking at the use of safe and well visits to detect mental health problems. And we're receiving this for information. Thank you.
Hi everyone, my name's Tamsin Fisher. Thank you for having me today. I'm a research associate at the University of Keele. I'm here on behalf of my colleagues on the Fireside team, and I'm with Carmel as well from Staffordshire Fire and Rescue. We're here to talk to you today about current research, nicknamed the Fireside Project, that's looking to understand if and how the Staffordshire Fire safe and well visits can be utilised to support the detection and signposting for mental health problems in older adults. This research plays a part in a wider project that's looking into the roles of non-traditional providers of care in the community. So why does this matter? Well, mental ill health is one of the leading causes of disability worldwide, and older adults who in this project we're defining as those aged 60 years and older are at an increased risk of loneliness and isolation, which can lead to anxiety and depression. Other life circumstances such as bereavement, loss and illness can also contribute to low mood. 1 in 4 older adults have a mental health condition, but only 1 in 6 are currently seeking support. There are a number of barriers that are preventing older people from accessing mental health care, including a lack of mental health awareness, stigma, and an unwillingness to seek help from healthcare professionals. Across the country, fire and rescue services are conducting home fire safety visits, which are sometimes called Safe and Well, as in the case of Staffordshire Fire. And the fire service are a well-respected emergency response and prevention organisation. So we've identified them as a non-traditional provider of care who could be used to help identify anxiety and depression in older adults. So we're using a multi-method approach. I'm not going to go into too much detail about this, but I'm going to be talking to you today mostly about the focus groups and interviews that I've been conducting with the Staffordshire Fire operational crews, technicians, community support officers and managers as well. So I'll be conducting a number of observations. I'll be going into the homes of 20 older adults. I'll be shadowing technicians and CSOs to understand how the safe and well visits go ahead. I'll be speaking to older adults on a one-to-one basis to find out whether or not they'd be open to opening up a conversation around their mental health with fire service personnel. I'll also be speaking with health and social care stakeholders. So I start my first lot of interviews tomorrow. I'm speaking to some social workers, but I'll also be speaking to police, public health, NHS commissioners, GPs, just to name a few. We'll also be conducting some stakeholder workshops later on this year. We're looking at sort of October, November time to discuss the findings and also to start thinking about what do we do with the information we've got and how do we develop some training for the fire service staff if that's the way forward, and where do we go next. I'm going to go over those 3 key points that I want to talk with you today from the data so far. These aren't exhaustive findings, they're just 3 points I think that'll be quite useful for you today, and I hope that you'll find interesting and hopefully useful to yourselves. So the Staffordshire Fire Service staff, they commented on their daily exposure to mental ill health. I went into this quite naively. I didn't realise it was something they were coming across on such a regular basis. They're regularly visiting service users with anxiety, depression, bipolar, hoarding, Alzheimer's and dementia, to name a few. So one CSO spoke of a house that had no heating and poor plumbing. The client or the service user was sleeping in their car to keep warm and was using a bottle to go to the toilet. He was living with severe depression and was known to many services, but due to the hoarding, other agencies were unable to access the property to help fix the broken heating and plumbing. He was stuck in this negative cycle of depression, deprivation and self-neglect. Suicidal ideation was also a common theme throughout the focus groups, and one of the staff members spoke of an occasion where a service user pulled out a blade during a visit and threatened to harm themselves. Another client spoke of his desire to die, and as you can see from the quote that I've listed here, he was saying he wanted to die. He said he wasn't going to eat and he wasn't going to turn his heating on. He was living on a farm in the middle of nowhere, and if he died that day, it would have been weeks before he was discovered. These are just some examples of the houses and the visits and instances of mental ill health. To better support their clients with mental illness, the fire service staff commented that they would like to receive additional training around mental health, which leads nicely into my next point. The technicians, CSOs and operational crews would mostly open to including more on mental health in their home safety visits. The CSOs in particular spoke of the challenges of mental ill health that they were dealing with on a day-to-day basis, but at present they don't receive much awareness training of mental health. So whilst most staff were open to expanding their visits to focus more on mental health, they acknowledged the need for training in mental health conditions, and particularly an awareness of the visual and verbal cues, signs and symptoms of anxiety and depression if they were to expand their visits. Also, and importantly, they expressed a need for training around communication techniques to ensure they were providing the appropriate support to service users and were equipped to respond to those who may disclose their experiences with anxiety, depression, and particularly suicidal ideation. The current Safe and Well form asks, "Are you depressed?" But there's little guidance on how to respond if somebody says yes. And we'll be addressing this in phase 2 of the research and also in the stakeholder workshops later this year. So a final point is to do with the well-being of the fire service staff themselves. So I've already mentioned, the technicians and CSOs, they're working beyond the realm of fire prevention, and they're regularly exposed to challenging and at times traumatic situations. So one of the key outputs from the focus group was the acknowledgement of the traumatic situations they found themselves in, and regularly, and they were commenting on the desensitization and the normalization of trauma. I mentioned the gentleman who wanted to die and the other man who pulled out a blade. These were just 2 instances in the focus groups, and there were many other examples I could have picked. All of the technicians and CSOs spoke of their frustrations of what they referred to as the system, and in particular the challenges posed by the thresholds that need to be met for clients to receive support from partner agencies. When the clients did not meet the thresholds, staff members commented that this had an impact on their own welfare and their own well-being. And a few mentioned that when their clients didn't meet these thresholds, they were struggling to switch off when they were at home, and they were ruminating on worst-case scenarios for the client. They were alluding to the weight of the responsibility that they felt for the client's welfare. And one CSO mentioned that they felt that they could easily be the last person that their client saw if the referral didn't reach the threshold, and or the time for expert support is days or weeks away. The fire service have excellent support available for their staff, and the Prevent team do an exceptional job of supporting one another. But there's no denying that what they're seeing is traumatic and is beyond the realms of fire prevention. Most of the technicians and CSOs agreed that the focus group helped them process some of the recent events and the situations that they had visited. And the opportunity to debrief and recognise that they were not alone was reassuring for them and gave them confidence that they were doing all that they could for their clients. In the wake of COVID-19, these opportunities to get together have been limited, but they were welcomed by all the technicians and CSOs. So whilst the staff were open to expanding the Safe and Well to include more on mental health, and they were keen to receive more training, they were also wary of the responsibility that this may be placed on them if they are upskilled in the area of mental health. And they raised concerns for the boundaries of their job role. Ultimately, their job is to prevent fire. They're not mental health professionals. And this is where further interviews with health and social care stakeholders are going to be essential to help us to develop a solution that works for the fire service, health and social care providers, and importantly, sufficiently supports the service users. The staff are all very passionate about their jobs, and they clearly want the best for their service users. The staff were keen to ensure that anything that they were including or expanding on the Safe and Well links back to fire prevention. The final concern for expanding the visits to include more on mental health was the implications on referrals. In an already overwhelmed system, the Fire and Response Service were anxious to not further overwhelm services, but also not to mislead clients in the hopes that they may receive care. Again, it's through these interviews with health and social care stakeholders that we hope that this may be clarified further and help to develop a pathway to support older adults living with early stages of anxiety and depression. And on that, I'm going to pass over to Carmel to give her perspective of the project.
Thanks, Tamsin. Good afternoon, everybody. So the fire service have welcomed being part of this project and certainly gained a lot already from the workshops that have been held. We hope it's going to allow us to have a better understanding of the communities that we serve, but also the impact on the visits to our staff when they carry out home fire risk checks. It's not just the community safety officers as well, it's operational crews as well that conduct Safe and Well visits. We need engagement for all partners to help us with this project, which is why we felt it was really important to come to the board to raise awareness of the project whilst it's going on rather than later on down the line, if you like. And also, as part of the National Fire Chiefs Council approach, we will be adopting the person-centred framework within Staffordshire. So that will upskill our staff. All prevent staff will have an apprenticeship which wasn't available to them in the past. So we're hopeful that we can upskill our staff in that way as well. Okay. Sorry, I haven't got my glasses on. You'll know that Staffordshire Fire and Fire Service generally are welcomed into people's homes, where other services and agencies have problems getting through the threshold. We don't have that problem. We want to keep that. We want to keep that trust, but it's really important that we understand that that's something that we want to maintain. Regarding the upskilling of staff around mental health, it's going to be an enormous challenge because, as I say, it's operational crews as well as our prevent staff. And also, as Tamsin's touched on, they're not going to be mental health. They're not going to do mental health checks, so they won't be doing anything around deprivation of liberties or the Mental Capacity Act, but they do need to understand mental health, and sometimes where they've said that person hasn't got capacity, understand what that actually means. What does that mean? Because currently we don't provide them anything with that. So that's something that we're looking at. And we're going to use the findings also to help our own staff, and Tamsin's alluded to the support that's available. So we do offer our staff TRIM, which is trauma risk management, really important after somebody's possibly passed away as well following a fatal fire, as well as any safeguarding issues that they come across. So we're going to keep these engagements, going to go to the Stoke board as well, and let people know about this project. As we go along as well, any key findings we'll report back to you, but certainly, as Tamsin's alluded to, there will be some workshops.
So just one final note, the next stages of the project, as I've said, is to speak to health and social care stakeholders. So if there's anybody in the room that knows anybody that may want to participate and would be willing to talk to us, would really appreciate the support. I can send information out if that's useful for you. My contact details as well are at the end of the presentation. I've just popped them up now. So by the end of the summer, we'll have completed all the observations and the interviews, we hope, and start thinking about the next stages where we will be developing hopefully some training for the fire service staff. That's all I have for you today, and I'm happy to answer any questions you may have, and I'm also welcome any feedback.
Thank you very much, Tamsin. That's a really interesting project, and thank you for the presentation. So any questions for Tamsin and Carmel?
Thank you, Chair. Just one question. What's your criteria for choosing your target audience?
So we're targeting older adults that over the age of 60, and we're accessing I call them clients or service users through the contact centre at the Staffordshire Fire. So we're in communication with the contact centre. The only criteria is over the age of 60 and receiving a safe and well visit. And that's the criteria.
Back on that, so you're not sort of selecting between what could be traumatised, shock from an experience of the fire brigade?
So sorry, did you mean
to select your targets?
In what sense? Because there's multiple different people with. So we've got the observations with older adults, then we've got the fire service personnel, and then health and social care.
Right, I'm just struggling to see how you're arriving at your 20.
So the 20 observations and interviews?
Yeah, and how you're differentiating between those that have maybe had shock trauma to a fire or another event.
So it's just anybody that is in receival of a safe and well visit. It's not necessarily if the client or service user has shock or trauma. We're just going to visit to understand how the visits take place, and how people receive the visits, and whether or not they'd be open to answering more questions on mental health, because currently on the safe and well visits they don't include much on mental health at all, so we're seeing whether or not it would be possible to include that to detect anxiety, depression.
Yeah, thanks for that. I'd welcome some conversations outside the meeting.
Yeah, absolutely. Yeah.
Thank you for that. It's very exciting. Thank you.
Thank you. Okay, so we've received this for information, and clearly it's very important to be able to raise the awareness of all these projects and similar projects, so that we are aware of this. And obviously, this is a great forum with multi-agencies and present. So in terms of, I mean, it's a 12-month project. So will you be coming back to the Health and Wellbeing Board to report on the findings?
If you would like me back, I'm more than happy to come back and present further findings as well. Hoping to collect the last of the data by August, September is the plan.
Okay, can we add that to the work programme?
Yeah. Do you know what's a reasonable timescale for that?
By the time data's been analysed, October, November would be a good time for the project.
Year,
or this year, yeah.
We'll add that to the
Is that okay?
So
yeah.
We'll be looking probably December.
Yeah, that's fine.
Okay, thank you very much. Okay, so if we move on to the next agenda item, I see Emma has popped onto the screen. So Emma's joining us virtually. So welcome, Emma, who is going to has come to present a paper to introduce this year's pharmaceutical needs assessment, which is one of the Health and Wellbeing Board's statutory duties. So over to you, Emma.
Hi, I'm not sure who's there, but just to introduce myself, my name's Emma Sandbach. I'm a consultant in public health at Staffordshire County Council. This should be really quick. It's just to sort of introduce what we're doing and sort of explain a little bit about the process. I'm not sure how much people know about the pharmaceutical needs assessment, but as mentioned, it's something that we have to do as a statutory responsibility. And it looks at current provision of pharmaceutical services across Staffordshire to make an assessment of whether this meets the current needs or future needs. So it looks at our population and sort of health needs in the population and potentially identifies any gaps in service. So it also looks at where the pharmacies can contribute to sort of meeting health need in the population. But one of the other things it does is provides an evidence base for NHS England and regional teams. So when a pharmacy applies to open, they have to sort of look at the P&A to make sure that they're, able to provide needs, or that there's, there's not too many current providers in the same space, so that everything's basically evened out. Basically, and I may as well mention this first. Normally, we publish the P&A at the end of March every year, but due to the pandemic, this has been moved back several times. So we have to have it published by the 1st of October, which has left us with extremely tight timescales. When we started to do the work for this, I tried to get something together last, was it September time? So we had a year's lead-in time, but because of Omicron, it was really difficult. So we kind of had to start the process after Christmas. So we've got all the data collected and the surveys back in that are required to pull this together. However, it's going to be quite tight to turn it around because we have to have a 60-day consultation period, which will run over the summer. So the initial headlines that we've got so far, we've looked at sort of the population health in this. We've got an older population than average, relatively affluent area, but pockets of deprivation which are quite severe. There's lots of factors in place that are increasing pressures on health services. So pharmacies are important as part of this. Higher levels of long-term conditions, which probably is based on the fact we've got an older population. So there's more demand for social care and health services generally. There's actually been a lot of changes in pharmaceutical services since the publication of the last one. And the government's actually put a lot more investment into pharmacy, really, to try and make sure people can access that instead of necessarily relying on going to other services. However, because of the funding, the funding settlement, despite that, there's been a reduction in sort of hours of operation of community pharmacy. I think that's largely due to cost pressures. So from living wage, pension contributions, and there's also workforce shortages as there are in a lot of areas at the moment. Most of the locally commissioned services that were available in the last one are still available. They have added some new services as well, I think, to this time. And they've also planned to have a look at new services around sexual health in the going forward as well. So basically, as I've mentioned, we're just sort of finalising all the surveys and writing all the results up. Some of that's done, but it all has to be pulled together into some kind of final document. And as I mentioned, the consultation will be available for 60 days. We're hoping to kick this off at the end of June, so it runs to the end of August. That will give us a bit of time to refresh the document in light of any of the changes that have been made. And then hopefully get it published by the 1st of October, which is the deadline. So really, for this, I'm just asking that you note the contents of this report. When the consultation goes out, what I'm proposing to do is send a link so that it comes around to the Health and Wellbeing Board, and we will also communicate that to all partners. And I know Healthwatch have supported us with the surveys, and hopefully they'll support us communicating the consultation. So if people want to make feedback, that's when it will be available to do that. However, what I would really like it if you could do is delegate, the authority to consider the responses of the consultation to the chair, so that the draft can be amended and approve a final version. Mainly because the date of the September Health and Wellbeing Board is early in September. Due to people going away on summer holidays, there won't be everybody around to make the final changes to it, which probably, in my past experience of doing this, haven't been masses of changes to make to the final document as a result of the consultation. So that's pretty much it. I don't want to take up loads of time with this because there's probably other things you want to talk about. Cute.
Okay, thank you, Emma. Certainly, this is one of the board's statutory duties. So so thank you very much for coming and outlining where you are with this process and what our responsibilities are over the next few months. So, does anybody from the board have any questions for Emma? Richard?
Not a question, but Chair, I think we should ask that when it does go live, we all get notified so that we've got the opportunity to look at it, read it, respond if necessary, and then inform that final version.
Yeah, no, Richard, that's what I was just saying. I think we need to make sure that the link's sent round to Health and Wellbeing Board members, alongside obviously more generally communicated to members of the public and other organisations who may want to contribute to it. So we'd welcome the contributions.
Yes, thanks, Emma, and we'll keep we'll look out for that and to have a look at all that information. So as a Health and Wellbeing Board, as you say, we note the contents of the report and we agree to support and feedback when that's made available to us. I need to, on behalf of the board, want to ask for the delegation to the chairs of the Health and Wellbeing Board to be given the authority to consider the response, amend the draft and approve the final version, as it's unlikely that the final report would be available for the September board. So is the Health and Wellbeing Board, are you happy to give the chairs that authority to sign that off for the 1st of October? Okay, thank you. So Emma, thank you very much. Okay, and we look forward to receiving the link.
Yeah, no worries. Hopefully in the next few weeks it'll be there. Thank you very much.
Okay, thank you.
Okay, bye.
Bye. Okay, so we're now moving on to our next agenda item, which is the partnership protocol. and Natasha's just joined us and this is a piece of work which has been going on for some time now, hasn't it, Natasha? All virtually, and Johnny McMahon and myself have been involved in this as co-chairs of the Health and Wellbeing Board, and it's to produce a protocol which to facilitate better joining up of and communication really between the chairs of the key strategic partnership committees and groups and the work and their responsibilities. I have to say Johnny has predominantly led on this because it's been very difficult with the meetings have always sort of clashed with my clinical sessions, and as I mentioned earlier, unfortunately Johnny isn't with us today with the change in his role. So going forward we will need to find a new board sponsor and a new chair to continue meeting with the other chairs in progressing this work. So if I could hand over to Natasha to update where we are with this. Thank you.
So yeah, as you kind of mentioned, we've brought this piece of work today, and it came about largely because our team are responsible for the Safeguarding Children Board, and as part of the conversations we were having about partnership working, of which we spend a lot of our time doing, actually it became apparent there was a lot of duplication between some of the boards and groups that were meeting, and quite often it led to potential duplication or even gaps, and so actually it was felt that it was worthwhile to do a piece of work to look at what we might be able to do to try and remedy some of that. So the partnership protocol is the thing I'm going to talk to you about today, but that's really the start of the process, I think, and not necessarily an end in itself. So you're asked to review the partnership protocol, to give us any feedback you've got. There's still time to do that, and then work with your sub-reporting boards to try and draw out what that looks like, so that we can try and have a look at whether or not there are some efficiencies that might be made. And I suppose it might be worth saying that actually quite a few of the examples that I could give will absolutely be pertinent, I think, to this group. So I'll talk you through some of that in a little bit more detail. So the governance structure, I think nobody would disagree that sometimes it can be complex. It's really difficult to map that out. I know that we talked to the police about kind of a mapping document that they got, and we matched it to the one that we'd got, and they were both different. And that was only for the children's part of the world and didn't necessarily include adults. And at the time, it included over 40 boards just for Staffordshire. So it gives you some idea, I think, to the enormity of the challenge and that we need to kind of consider really as we move forward. And what I think became apparent when we were doing that mapping was that quite a few people had got a vested interest in a particular topic, but quite often some of those issues that people were meeting about were interdependent and not actually working with one another in the best interest of families or people that might come into contact with them. And a lot of the feedback we had from the district chief execs was actually, you know, maybe there's opportunities here to work in terms of better place-based working and not necessarily around thematics. So I think what you can see when you look at that mapping is that actually it's really difficult to know who's accountable and responsible for different pieces of work, because when you look at the terms of reference for the different groups, there's quite a lot of overlap and duplication in terms of what those groups are doing. And so it felt like the best place to start was trying to get that join up at the top. So for the Health and Wellbeing Board, for the Safeguarding Children's Board, for the Safeguarding Adults Board, and for the Community Safety Board to come together to really have a shared understanding of who's responsible and accountable at that level for different areas of responsibility. And also, how can we work better together? So a really good example that we've talked about with Johnny, for example, was that actually there's a lot of work going on in relation to drugs and alcohol, and that will absolutely have a kind of community safety dimension. It will definitely have a health and wellbeing dimension, and it will impact on both adults and children. So that's an example where actually there's a cross-cutting issue that doesn't necessarily sit with one board, but actually might have interdependencies across the four groups. And I think what actually happened was that by some people taking responsibility and ownership, other people felt like they were missing out, so setting up subgroups that sat underneath that created some of this bureaucracy, I think, that sits underneath it. What became clear when we did some of this mapping work, that there was a real lack of connectivity between the different boards. So at the last count, we've got 4 groups that have got infant mortality as a priority. None of those necessarily talk to each other, nor have the same people on them. And so actually there's a real difficulty, I suppose, in trying to hold people accountable, but also kind of make sure that we've got that join up. And because of that, sometimes there's duplication or potential gaps. And again, in the infant mortality space, I would say that actually there's a lack of a doing group as opposed to somebody with strategic leadership and oversight for it. And what might be helpful, I think, is that the strategic groups agree who's responsible for that agenda and get that doing group to kind of get some of that action taken forward, really. So the idea behind this was that we looked at other local authorities and said, well, what do other places do? You know, there's no point in starting from scratch. We'll absolutely pinch with pride. And what a lot of local authorities do is something called the partnership protocol. And as I said, that's really the start of the 10, really. It's putting down on paper how we propose that we'll work together. But actually the bringing to life of that is absolutely dependent upon the chairs and also the people who attend those boards. And we felt that actually that would be a good start, I think, in trying to get some consistency and agreement across the different partnership boards in terms of how we might be more efficient and achieve better outcomes together. So it's not about kind of stopping anybody doing anything that they're statutorily responsible for, but it's about providing clarity about who's doing what, where and when. So we thought that the benefits of delivering a protocol, and we did talk to some of the local authorities, so we saw Somerset, Manchester, all kinds of people. Some of the benefits that they saw was that actually you had a better, more cohesive view of health, safety and wellbeing in the round, that actually you were talking to the right people about the right parts of the agenda to make effective decisions. And actually there was greater clarity in terms of who were the lead partners in terms of some of those agendas. So actually having the conversation at the start, actually who's best placed to lead this agenda and how can you link with others, is probably a better starting point than kind of fumbling away through some of these discussions. What we found when we talked to others that there was better clarity in terms of partnership boards, and then what that meant was that their reporting structure underneath that was much leaner than ours. So most of them didn't have in excess of 40 boards like we do. We felt that actually from speaking to people there was a lot of kind of benefits really in terms of shared appropriate information across different people, so that actually you could engage people in the right discussions and decisions about those, but you didn't actually need a governance board all the time to do some of that. It was just about knowing who was where. That you needed to link in with. And there was definitely a feeling that actually you got a better response to problems, because actually you could see the problem from multiple different angles and have the discussions with the right people. So actually most people felt that there was a benefit to this, albeit, and I will say this again, that isn't going to be achieved through the piece of paper. That's about the people doing what we need them to do outside of that. So we've pulled together a partnership protocol that's been worked through with the chairs of the different boards, and as I said, Johnny was involved from this group, as have the other chairs, and they've tried to get something that they're fairly happy with to then bring to you today for discussion and additions really. So we've included a copy of that in the pack, and like I say, we are still open to feedback about that. But it's not the end. So there's loads of different stuff out there around what makes good governance, and some of this I know is kind of close to conversations that have happened with people recently. So I'm not going to kind of regurgitate some of that, but actually it will be very much reliant on the chairs continuing to meet to discuss the joint work and to bring that to life. And I think actually for us to do that, some of that will be about understanding shared priorities and agreeing who's accountable and responsible for what. And it might also be about challenging ourselves instead of setting up new boards, that actually we're clear about where are the best placed people to deliver this piece of work. And actually sometimes that might not be convening around topics, but more around places. So I think what we're asking for you is for your support to continue to drive this agenda forward, to continue to support us to map out the governance that you've got kind of working on your behalf, and to continue to engage in some of those conversations to try and make us more efficient and leaner in terms of the way we work together. So that's it from me. I shall take any questions or comments.
Thank you very much, Natasha. So any questions or comments for Natasha at this stage? Julia?
It's just a comment. As the County Council officers know who were at a meeting yesterday, this is music to my ears. Anything that actually cuts back unnecessary bureaucracy, which actually impedes progress, has got to be a good thing. So I think this is the right direction to go into, and certainly support it. Thank you.
Thanks, Julia, and I would agree. Helen?
Thanks. And Natasha will know this is a piece of work I've been chuntering about for years, and John, by the look on his face, to try and move forward. I guess one thing that I would like us to consider in the future and it will be a very difficult thing to consider, I think, given some of the structures we've got. But there are parts of the country where those high-level boards are even less in number, including across safeguarding of children and adults, where in many parts of the country now there is one safeguarding board that deals with the continuum. And I think a gap, and I think that's a thing to think about. But I also think it addresses a gap which has worried me for some time, which is around transitions. And I think we've got two different offers, which is right in a way that, because of statutory responsibilities, but how we manage that smoothly across all the various cohorts, including those young adults with significant mental health challenges as they move through the system, I think it's really important that we don't lose sight of them. Mm-hmm. And I guess that would just be something, I think, just play into the development work.
Yeah, I mean, that would be an ideal thing to look at, wouldn't it, through this work? Phil.
Thank you, Chair. Yeah, very much welcomed from the voluntary sector. I know Natasha and I have had conversations around this. I welcome the fact that this is just as the start as well, but I suppose trying to think ahead, how will we know we've got to where we want to get to? Is it just going to be a feeling that our diaries haven't got as many partnership meetings in them? Or is there a way of measuring this more tangibly? Or have we not even got to that stage yet?
Can I come back on that? So I think that would be a really nice feeling, Phil, to have less meetings in my diary and more thinking time would definitely be a bonus. But I think for me, I think us having a shared understanding of what the governance structure looks like in the first place would be a starting point, because I don't think we've got that yet. I think a leaner structure, because I still think that there are some boards that we probably don't need. And I think actually probably better working around that place, because quite often I think the issues are not issues on their own. They are the same people that we're probably talking about multiple different times, and when Helen's talking about the child, Rich is probably talking about the adult. So I think for me it would be better kind of working around that person or that family or that resident, as opposed to necessarily our thematics. I also think, Phil, a good measure would be our ability to switch stuff off, like to meet for a period of time, to do a focused piece of work and then stop, because actually sometimes that's what's required. And I think quite often we add as opposed to stop. But ultimately, I think it would be, again, a sense that we all understand what each other are doing and can kind of point or get ourselves to the right direction in order to have some of those joined up conversations in the best interest of people who live here.
So, the feeling in the room is that this is a really good idea, and a project which, and you know, some work which has started and has got a long way to go, but certainly is very welcomed. So I think my question would be, well, a couple of questions really. So the first thing is, in terms of feedback on the protocol, it's in the pack. Would you like us to feedback if we've picked anything up by email? It's probably... Yeah, okay. So if we feed back to you, Natasha. And then I think the other thing is that, I mean, sitting on this board, I really, you know, knowing what happens sort of underneath this is really complex, and it's going to be complex within all those sort of, with all those strategic partnership structures. So I suppose it's, what do you need from us in terms of, do you need an operational lead, or have you got an operational lead?
Yeah, I think it would be beneficial if somebody from the group could be identified to work with. As I know, John's been involved in helping shape partnership protocol in terms of giving some of the information we need. But I think in terms of that mapping, it would be helpful if you identified somebody who would be able to do that. I suspect once we get to a point in time, we'll need to come back and say to you, actually, we think that there's some duplication here, and again, engage you in that discussion. So again, their support in that would be very helpful, I think.
Yeah, and I think that's when you come back, you know, when you would come back with sort of an update on how it's progressing. I think that's really important for the board to understand. So I'm going to look at John in terms of an operational lead. Yeah. John's the man. Okay, thank you. So have you got everything you need from us, Natasha, today then? Yeah, I think that's great. Yeah, it's focuses the mind.
We'll put a reminder out as well.
We will put a reminder out. John's already being the operational lead. Yeah, okay, thanks very much, Natasha. Okay, so we're now moving on to Baz, who is here from Health Watch, and to give us an update on the Health Watch provision, which has now been supported by Support Staffordshire. So, Baz, over to you.
Hello everyone. My name is Baz Tamiz. I'm the Health Watch Manager now for Health Watch Staffordshire. And as you've just stated, that Support Staffordshire has been awarded the contract to run a refreshed Health Watch Staffordshire commencing from the 1st of April 2022. I'd like to start with our vision to help people get the best out of their local health and social care services, both to improve them today and helping to shape them for tomorrow. So, as part of the Support Staffordshire governance, an independent Health Watch committee has been established. This will hold delegating decision-making powers to set the Health Watch agenda. This will consist of 4 unpaid Support Staffordshire trustees and at least 2 independent lay members who will form part of this committee. The Health Watch team itself will have a Health Watch manager, which is myself, and 4 engagement officers to cover the southwest, the southeast, the north, and a social care focus post. All 4 posts are at 30 hours per week, and we will also have 1 project worker data analyst to support the team to collate the appropriate feedback and to help create the reports, who will be working at 22.5 hours. We have obtained a list of volunteers from our previous provider, and we are currently in the process of reaching out to them to induct them with Support Staffordshire and training, and we will then be looking at expanding on our existing volunteers to diversify our volunteers. Some of the areas we'll be looking at are organisations such as expert citizens, who are people with lived experience, and also those from hard backgrounds, so they could be people from the homeless community, substance misuse, mental ill health, and involved with criminal justice services, who have then gone on to become functioning members of society and now giving back as volunteers. We'll also be looking at working with our partners within the NHS and social workers for student placements. This is to help support, one, with our volunteers and diversity, and also to help potential future workforce to see the patient voice. We will also have other areas that we'll be looking at, such as research and data analyst and seldom heard groups, to again reach out to those hard to reach groups. As part of our collaborative working, Health Watch Staffordshire will work closely with the voluntary community social enterprise, public and private sectors, to ensure high quality care based on patient user feedback. We will take a collaborative approach with key partners, stakeholders and volunteers in the pursuit of best practice informed by the public's opinion, to contribute to the local voice, to deliberations and strategy of Health and Wellbeing Board, ICS and commissioners across the health and social care system. We have reached out to Health Watch Stoke-on-Trent to establish a collaborative working relationship to support the local health and social care system, and will work closely with Support Staffordshire social prescribers. We work collaboratively with Health Watch England to improve on good practice, implement best practice, including ongoing Health Watch England meetings and communication, to standardise our website to be in line with Health Watch England. To further build on this, Health Watch Staffordshire will be establishing a Health Watch intelligence network to engage multiple platforms for gathering health and social care data. This will include local Health Watch Staffordshire events, with relevant VCSC groups and communities, support Staffordshire VCSC locality forums, VCSC healthy communities forums, and will also work with the PPGs. We have a grant fund in place to enable engagement with communities to focus on extending our reach, in particular to seldom heard group, protected characteristics and rural communities. There will also be a social care focus with our social care engagement officer with the aim of increasing social care feedback. We will be working with our partners not to duplicate efforts. Other intelligence feeds include website feedback centre, free phone, email, face-to-face, social media and events engagement. In addition to using the data we gather, we seek closer working relationships with Staffordshire Observatory, who are a highly skilled team of data and research analysts that reside within a wider strategic team within Staffordshire County Council to share data in both directions for mutual benefit within GDPR. In addition to gathering resident patient feedback in the round, we will target focus on 3 to 4 focal topics for deeper investigation, reporting and recommendations. Year 1 focus will be informed by lessons learnt through the pandemic, and future years will be further based on patient feedback. So some of the potential focal investigations are health in parents of young children, root causes of good and poor teenage well-being, health outcomes when you've been in care as a child. My health isn't just my disability diagnosis. Being an LGBTQI+ patient resident in the health and care system, accessing primary care face-to-face when I want to and when I need to, the role of and accessibility of residential care by friends and family, how and why we ignore the inevitability of death and dying, frailty, old people accessing services, and transitions in and out of hospital. So HealthWatch has a statutorily backed right to enter and view any healthcare premises within certain parameters. Historically, this duty has primarily been used to enter and view residential and nursing homes in the private sector. We will be reviewing how we use this power with a view to greater coordination with statutory quality and safety teams at Staffordshire County Council and NHS. We will be communicating our role and outcomes to the public. We have inherited the website, and this has been refreshed to reflect the key changes. We're working with HealthWatch England to implement a standardised website template and further update. The social media tools are now in the process of being accessed by all staff and being updated. We have had initial promotion in the My Staffordshire in June, which has reached to 14,000 residents. We will be working with partners to ensure good local health and care information, advice and guidance is available and accessible. This has come at useful timing with the current review of Staffordshire Connects. This function includes connection to NHS complaints advocacy, now delivered by Assist. So as part of systems change, we will be further engaging with statutory organisations, partners and boards to present findings and influence systems change. These will include Health and Wellbeing Board, Health and Care Overview and Scrutiny Committee, Integrated Care Board and Partnerships, NHS Patient Engagement Structures, NHS Quality Teams, District Borough Councils, HealthWatch Stoke-on-Trent, HealthWatch England. HealthWatch Staffordshire and Health and Care Overview and Scrutiny Committee have had early engagement to further develop working together and joint guidance produced and working relationship established. Thank you.
Thank you, Baz, for that update, and we've been asked to note the contents of the report in your presentation. So I'm going to ask if any members of the Health and Wellbeing Board have got any questions or comments for Baz. Mark, sorry, yeah.
No, that's no problem. Don't know whether I got a previous version because I didn't have that presentation on the paperwork on mod.gov, but having read the actual report, paragraph 16 talks about potential year 1 areas for the focal investigations, and it goes from A to L. There's an awful lot there. How will you decide which ones you want to look at? because I'm pretty certain you're not going to be able to do all of them, are they? And some of those areas, and I take C, which is a particular interest to myself, which is the health outcomes for people who've been in care as a child. How do you have access to that sort of data?
Thank you for that. Yeah, we've been talking to our partners and across different boards, and we are looking to finalise on, as mentioned, 3 to 4 particular areas, and that's also to avoid duplication. Because I've spoken to those partners, there is focus in some of those other areas. So we will be summing that down in the next 2 weeks, I presume, and have those particular areas. So yes, there is some data behind it, but it is working partnership with our partners to get that focal down to those 3 or 4. Because like you said, it would be a lot, and we wouldn't be tackling all in one go.
I suppose just building on that as well, I mean, we've just been talking about priorities for a health and wellbeing strategy, and same's happened last year in Stoke. I suppose again it's how these complement all the priorities of the partners across the system. So and it's certainly very valuable work when you do your deep dives into these areas. Okay. Oh, Julia. Yeah.
Just a very brief comment, because you've only taken this contract over since the 1st of April. And it's really to give some assurance. I have a meeting with Baz and our commissioning officers, and I think they have to be congratulated in the fact that there has been a smooth transition of the service from the previous provider, which bodes well for the future. So I think we all look forward to working with reinvigorated Health Watch, because I think it's invaluable to have that independent feedback from users of all our services. So it was just to give that assurance.
Thank you, Julian. That's really important for us as a board to receive that assurance. Okay, thank you very much, Baz. Okay. So, moving on to the final agenda item, it's the forward plan. I'm going to hand over to John.
Relatively short, I think. The full plan is in the pack, but obviously the P&A Pharmaceutical Needs Assessment will be dealt with slightly differently now, and we'll get that circulated as soon as it's available. The other agenda items that's on the pack are the health in early life, which is one of the strategy priorities. So that kind of goes hand in hand with probably bringing back the strategy, actually, based on the conversation earlier. And Airware was another one that was linked, and there'll be others, but that's what we've got so far on the kind of like forward plan.
Okay, that's for the next meeting, which is on the 8th of September. Is that right? Yeah. Okay. Okay, thank you. So, is any comments on that forward plan from anybody from the board? Everybody happy with that? Okay, so I just wanted to just raise something when we come as part of the forward plan, and the fact that so as I previously mentioned, Johnny will need to find a successor for his co-chair role, and having spoken to Richard and John and Julia earlier, that's being worked through at the moment. So the board we will inform the board when that's being worked through and a decision made. I would also like to just highlight that my role as clinical chair of North Staffordshire CCG will come to an end on the 30th of June as the CCGs are disestablished, and will be handing over to the Integrated Care Board when that comes into being on the 1st of July. So I have spoken to Peter Axon as the Chief Exec of the ICB to highlight that to continue the working and joint co-chairing, that we would be looking for somebody from the Integrated Care Board to take over as co-chair of the Health and Wellbeing Board. And again, that is as with was with the County Council. That's work in progress at the moment. So once the ICB comes into being, then there will be an update of who will be nominated to co-chair, along with the County Council representative. Okay, so this potentially is my last board. So Richard.
Yes, Alison, just on behalf of all of us, just thank you very much for your efforts in chairing this board for the last however many years it is. That's a long time, isn't it?
Yeah, I'm trying to. Yeah, it probably is. It's probably is about 3 years, isn't it?
So yeah, it's been long and.
It is, yes, it's been. No, it's been very enjoyable, and I hope I've come up to expectations.
Yeah, it's been a long and interesting journey. So
yes,
thank you very
yes,
much,
thank
and
you.
wish you all the best in what you do next.
Yes, thank you very much, Richard. Okay, so we've come to the end of our meeting today then, and so the next meeting is on Thursday, the 8th of September. Sorry, Mark?
Just very briefly, if we're saying goodbyes and thank yous and what have you, of course it will be Helen's last meeting of Health and Wellbeing as well, as she retires as our Director of Children's Services at the end of this month.
Okay, yes, sorry, Helen. Nobody reminded me. So yes, so yes, it's going to be a few goodbyes, isn't it? So yeah, and all the best, Helen, for your future as well. So so I didn't actually ask if there's any other business before I attempted to close the meeting there. So nobody's got the hand up. So yes, I'll bring the meeting to a close, and the next meeting will be on the 8th of September. Okay, thank you, everybody.